Our guest this morning, the Secretary General of the Kenya Medical Practitioners and Dentists Union, Dr. Davji Attelah, joins us in the studio today alongside Reverend Elias Agola, the National Council of Churches of Kenya, and from the Christian Aid Organization, the Pan-Africa Senior Advocacy Advisor, Joab Okanda. Gentlemen, asante sana for joining us. Welcome to Kenya's biggest conversation.
Thank you.
It's good to have you on the show, and we appreciate that you have joined us this morning. Daktari, it's the first time that you are in the studio. We've had very many conversations with you.
Yeah, we have quite a number, but most of them have been online, on Zoom, and on phone. So I think it's the first time you're now physically on the studio.
Karibu sana.
Asante.
Karibu. Mchungaji, karibu pia.
Asante sana.
It's good to have you on the show.
Asante sana.
What role do you play in the National Council of Churches of Kenya?
Well, in the National Council of Churches of Kenya, I play several roles. One of them is being an advocacy person, talking on issues, whether it is corruption, COVID-19, and any other issues that the church assigns me to do at the NCCK. Like this time again, we are talking politics and elections, and we are here today I'm here to talk about COVID-19.
True.
Thank you.
Which church and denomination do you represent?
I'm from PCEA, the Presbyterian Church of East Africa.
Mm-hmm.
I serve here in Nairobi, in Kahawa West, the northern part of Nairobi, which we call the Nairobi North Presbytery.
Okay.
Thank you.
And Joab Okanda, welcome to Kenya's biggest conversation. You are from Christian Aid. Who is Christian Aid?
Thank you, Eric. I'm happy to be part of the Situation Room today. Christian Aid is a global movement of people, churches, and local organizations that stand together for dignity, for equality, and for justice.
So what does that mean?
Poverty robs people their dignity.
Yes.
And so we have to fight the root causes of poverty.
Mm-hmm.
So we stand together, we bring people together to fight the root causes of poverty that rob people their dignity. We stand for equality and we stand for justice. When
an organization is called something aid, you think of receiving aid and support. Is that what you do? Humanitarian aid?
There are situations that require humanitarian support.
Mm-hmm.
And, when we start a conversation around aid, I know it's a conversation that will take a month to have. Because are we talking about aid itself, or we are talking about justice, we are talking about restoration,
Mm-hmm.
Aid itself keeps people in dignity, actually. And, it comes up with colonial connotations. And even internally within Christian Aid, we are having a conversation whether we should keep the word aid as part of the organization's name.
Good. What would the other names be? Christian support, Christian advocacy.
Actually, what I'm concerned about, aid, we understand the term with all the connotations. So, but when you prefix it with Christian, how then does it differ from others? What is it that you do that is specific and unique about what it is that you offer?
The name came about when the organization was founded about 75 years ago, when churches came together to support those who are facing humanitarian disasters, those who are actually were suffering under the hands of colonialists, so this was a movement that came, for example, in South Africa to fight apartheid,
Mm-hmm. Yeah. So, back to that question. If you were to move it from the name aid, what else would it be called? Christian. So Christian is staying. Aid is what, now we may have to change from Christian aid to Christian.
My question hasn't been answered yet.
Christians.
The reason why I say this, colonial connotations notwithstanding, anyone who professes to be of the Christian faith, the issue of assisting those in need, it's not a suggestion, it's mandatory. We have a prelate here. He can confirm whether what I'm saying is a figment of my imagination or whether it is true.
Yeah, it is true. Whenever you mention a religion, Christian for that matter, you have to have in mind that the issues of aid, support, having initiatives and developments and advocacy for the less fortunate or the faithfuls is not something that you do as an option. Even if you have to acronym AID, you can say advocacy, initiatives, and developments. That can also be part of what the Christian aid do, and all that is about support to the people that you target as your persons, as your target for operations. So even when my friend is saying Christian aid is a name that was initiated long time ago, 75 years ago, again, even today, it is still relevant. I think you are right in asking that question, and I'm sure I've answered you. Yeah.
Yeah, I think otherwise, having it as Christian aid is still the best, because it actually fragments the different roles that the Christianity plays. So this is just to help and to empower the humanity and to assist on that aspect. I think that will really make it different from the religious aspect.
Okay, Joab, focus group discussion, you get your answer, right? Daktari, we have been talking a lot about COVID-19 for the last 2.5 years or so. COVID-19 in the country, the response by the government on COVID-19, formation of the National Emergency Committee, Response Committee, formation of the task forces, daily communication from the ministry, a reallocation of budgets to fight COVID, and very many things that have happened, where we get to a point where yesterday's positivity rate was 0.2%. Okay? So if we were to look at it broadly from a universal point, how have we fared in responding to this global pandemic as a country?
I would say that if you look at the Kenya, or as it is in response to the COVID-19, we've fairly done well. And this is in the sense of communication. When COVID came in the year 2020, there was a lot of panic that was among the public and everybody. Nobody knew what COVID was. And even if there was information that somebody is infected, the reactions were very unique. But then I think the government took an initiative of giving information almost on a daily basis. And that information really made people to understand the prognosis and how COVID was relating, to the point that people understood that if you get COVID, you can actually get well. They're giving the statistics of those who are infected, the transmission, the deaths, and even the recoveries. So I think that information really helped people to understand, and even the trends of different places. Generally, again, also we have the people who were affected, those who lost their life in the process, a number of them, and some were because of the facilities that they were into. So in one way, I can say that the way the government handled the information part of it was good, and the way it exposed the inefficiency that were in the public sector facilities, and it made many people to see that the healthcare actually it plays a pivotal role in the country, or the sector, or in any setup. And again, it made people to see also the healthcare workers in a different way as before, that actually they are like front soldiers that will put their life in place to support and to help the country. So basically, that really made a lot of policies that have been developed, and even the way that the public has taken steps in it became very different. Yes.
So there was great improvement. Yes. And Reverend, if you look at the entire response, of course, religious organizations were central to this dissemination of information, to making sure that everybody understands what they're supposed to do. Religious organizations were immediately affected by the lockdowns, by restriction of movement into places of worship. But also religious organizations, also in terms of playing that important role in the community as influencers, religious organizations also sponsor very many health facilities. How would you rate our response, and what are the positives and the negatives that come out of the COVID-19?
Well, when COVID-19 struck in March 2020, the first entity that was struck was the church, because church is a gathering, it is a congregation, it is a people coming together. And not only the church, we have the Muslims, that is the mosques, we have the Hindus, that's the temples, and under the IRCK, which is Interreligious Council of Kenya, the church came together and the religious institutions came together. And our main role was to ask the people to be calm first, to obey what the government is directing, and we were also there to give hope to our people that it's not all until it is all. We are not done yet. We are still alive, we are still existing, God is still in control, and we know that things will stabilize. So we continued with that message of hope, and we also asked our health institutions to team up with the government so that whatever the government instructs or requests to be done should also be done in our health facilities. And most of our health facilities were engaged with the government.
In your opinion, are there things that we should have done that we didn't do? Or are there things that we were saying we are doing, but in reality we were not doing?
Yeah, humanity is a difficult species to deal with because they think, they have their own opinions, and at that time again, most of the religious institutions have got their own theological interpretations, because although we have a standard Bible or a standard Quran, but the interpretations are with the people. So sometimes when you ask the people to mask up, people could not mask up all of them. If you ask people to isolate or not to go to crowded places, you would still see people go to Gikomba. You would still see people, sneak in and maybe have their own in-person meetings. So again, we can't say everybody did everything at the same time, but again, it depends on where people were.
How about the government? Was the government doing everything that it ought to have done, Joab?
Yeah, I think as Davji said, the government tried in terms of communicating the impacts of this pandemic. But where I found the government failing is actually when we started getting COVID-19 vaccines. We didn't see the same energy that the government invested in telling people to social distance, to wash their hands. We didn't see that actually happening. The government did not go out there aggressively telling people to get vaccinated, but instead it started using some militaristic approaches, saying you'll not have access to government services if you're not vaccinated. You will not access malls if you're not vaccinated, And we know the myths around vaccines and not just COVID-19 vaccines. So if the government would have put in the same effort, we would have seen a difference. The other thing that I think the government missed a bit is in terms of protecting the most vulnerable, and we've seen the social protection systems. Where has the money gone? Government responses, fiscal responses to this pandemic, to be honest. They reduced, for example, the pay as you earn for certain people. But it also reduced corporate income taxes, for multinationals to 25, from 30% to 25%. This means the government was collecting less, actually, to invest in public services.
Not necessarily. Not necessarily. If you look at it literally, it appears that they're collecting less. But sometimes, not in this particular instance, if your tax is fair and it's considered to be manageable, you actually make it possible for more people who ordinarily would have avoided paying tax to actually pay. So you actually end up even receiving more money than you would have received otherwise. When you make it punitive...
Theoretically.
Yes. No, actually, it's practical. When you make it punitive, more people avoid paying taxes even where they could.
That's true.
Case in point is during the Kibaki era, if you look at the conversations around tax, what is it that made that government able to collect money? They didn't keep hiking taxes. They didn't tax you at every turn. They rationalized it and they brought about ways, it means they were having conversations with you about how to pay your taxes.
But specific to the stimulus program that was announced by the president, with the reduction in pay as you earn, with the reduction in income tax, did the government then collect less than it could have?
Let me ask the question.
From the same organizations.
Is there evidence that the government collected less? Because this is something that is empirical. It's something we can determine.
Yes.
Yeah, there is actually evidence that the government collected less. You know, if I was paying 30% and I'm now paying 25%, and we are talking about those who are earning highly. You know, we are not talking about those who are earning the minimum, you know.
So were they collecting less because they reduced the taxes, or were they collecting less because more people are not able to pay?
They were collecting less because they reduced the taxes. You know, they were saying we want to
From a potential pool of the people who've paid tax, you started the financial year projecting that these people, the five of us in the room, were going to pay X amount. And then you've reduced it by 5%. Yeah. If all of us still end up paying, you have collected less than you had projected.
But I think we need to go back to the context. The question is, what did the government do and how did it do it? The context is the COVID-19 time.
Yes.
And the government had an initiative to have taxes reduced. So whether it was paid less or not, we focus on, did the government do something to at least relieve people during that time, so that at least if they were to pay 30, whether more people now paid or whether less people paid, that depends on the data.
The question
but now we have to look at it at what did the government do?
What was the intention of the government at the point?
What was the intention of the government?
Is actually, who was the government cushioning? Was it the poor or was it the rich? You know, it was a good thing that the government reduced taxes for the most vulnerable, for the poorest, for the low-income earners. But this was applied to everyone, whether you're earning 3 million a month, you know. And beyond that,
Pay was only to a certain level of income, up to 25,000. That's what it was waived.
That was what was waived, but
yes.
The rest was reduced. You know, there was a reduction by a certain percentage to all those who are paying payee, and then the corporate income tax also was reduced from 30% to 25%, and you can see the impact of that when that was removed now.
So what is your argument then, Joab?
My argument
is this, the government actually supported those who are higher incomes, the rich more than the poor.
Yes.
Demonstrate that. How?
Because if I'm earning 3 million shillings and I've been paying I've been paying a tax of 30% from that income, and you give me 5% tax relief, and you also give someone who's been earning 150,000 a same percentage of tax relief, you see the amount of revenue you're losing from the one person earning, the 1 million, who is less impacted by the pandemic. And this is the money that you really required to actually strengthen your public health systems so that you can respond to this pandemic. So it is about having a blanket relief for everyone, those who are high income earners and those who are low income earners.
In your opinion, what should they have done?
In my opinion, the government should have provided a relief up to a certain level. Let's say those who are earning maybe up to 150,000, and those who are earning higher than that, let them continue paying.
Dr. what do you think?
I don't think I agree with Job on that. Because I think the thing is pay as you earn. So it's on a tax, there's a level for it. And then when there was a reduction in that amount, it meant that the working class were able to get a little bit more money. What I believe this was going to help with in every way is to cushion everybody during that particular COVID, because the economy was affected. So if the tax was less, if it could have been less all through, that's the amount you're paying, then I think if we're paying less tax, less better, because then we have more money in circulation, more money to help many things, to help many activities. So I believe if we say that the more the government tax during the COVID, they will have more money to really help mitigation. And that was not the case, because during this period of COVID, we had a lot of grants that were being sent to the government, that were helping the government to handle this. But I think some of them went into very wrong hands, like we saw the case of KEMSA, where we ended up having a lot of billionaires from that particular scandal. And I'm sure there are others that probably have not been mentioned, did not be talked about, but occurred, even in the manner that the communication was taking place, the ministry. And if that is the ministry, what then happens in the counties? Many counties could not account for millions that were there for COVID-19. And that's why one thing that's I had to add on the government not doing was part of the human resource for health. During this pandemic, we realized the essence and the need to have healthcare workers. But then the shortages that we have in our facilities existed before COVID, existed during COVID, and they're still in existence. But we have a very big number of doctors that have graduated over the years that are outside not working. We have a big number of clinical officers, a big number of nurses. So you realize that you go to the hospitals and you're not able to get services, not because there are no doctors that have been employed, but there are so many doctors outside who will be working in the kiosk, maybe selling mandazi.
Let me ask this question.
Yes.
When we train healthcare workers,
Yes.
is there a plan to determine how many healthcare workers are trained to meet the need that we have in the country? Or are they just trained because the training facility exists and people have applied?
Because they're universities and people have gotten A's. Let's answer that question after we take this break. Okay, it's 8:30. This is Kenya's biggest conversation. It's a Situation Room on SpiceFM, KTN Home, and online on YouTube and Facebook. It's Eric Latif and CT Muga today. Our guests are Dr. Davji Attelah, who's the Secretary General of the Kenya Medical Practitioners and Dentists Union, Reverend Elias Agola, advocacy person at the National Council of Churches of Kenya, NCCK, and from Joab Okanda is a Pan-Africa Senior Advocacy Advisor at Christian Aid. We are talking about COVID-19 and basically just doing what we've been saying we want to do. Have an audit. Let's look at how have we managed COVID-19, both as citizens and as our government. We'll be back shortly. Good morning. CT, you had asked the question about planning for human health in human resource in healthcare.
Yes.
We train, we don't employ.
Well, my question really is, can we absorb everybody that we train? More specifically, do we need everybody who we train?
Let me give you, for example, with the doctors. The WHO recommendation for the doctor to the patient ratio is 1 to 1,000. But as you are in Kenya, as of now, we have 1 to 16,000.
Sorry?
1 doctor to 16,000 in a population.
Which means you've answered my question. We need every doctor.
We need every doctor. And that's what was happening up to 2014, where every doctor who graduated from the university was being absorbed into facilities. But then I think when now it's with the budget is with the counties, then now the employment reduced drastically, up to about 70% in reduction. And then you look at the facilities or the hospitals. The hospitals are based into level 1, level 2, up to level 6, based on the service delivery. And the service delivery is done by the workforce, the personnel. So if you have a level 4 or a level 5, according to the regulation from the KMPDC, you need to have a particular number of doctors. Level 4 need to have at least 50 doctors. Level 5 need to have at least 70. But then you realize that in those particular public facilities, the numbers are, for example, level 4, you'll get 10 doctors. Level 5, you'll get maybe 20 or 30. So with that, the service delivery will actually be hampered with.
And are the specialties also supposed to be represented at these various levels of hospitals?
Yes.
And we find that is lacking.
That is completely lacking. And it's lacking not that because they're not doctors who have graduated and are available in the market. It's because the budget constraints that are being said by the governors or by the ministry not to employ. So then the people end up not getting services in the hospitals when they go to get.
I need to ask this question. It's an unfair question, but maybe somebody can answer. Is what was the rationale behind devolving health?
The aspect of devolving health was to make, just the way of the evolution was to bring resources and everything to near the people.
Yeah, but even when it was under the national government, resources were still being brought to the people. So, is it to give this false sense of control?
Yes.
And yet there's none because you don't have the resources to actually run that particular.
I think the question should be: we devolved the functions. Did we devolve the resources? Did the resources actually leave the national government
And follow.
and follow the
functions.
services? That should be the question.
And maybe another question would be, are the medical persons happier in the national government than they are happier with the devolved government?
I think that's
Do you think if it is reverted, then all the doctors trained will be absorbed?
The thing is this: I think we've all seen how many industrial actions we've had in this country. In fact, latest being in Mombasa and in Taita Taveta and some other places, where a time has come whereby the county budgeting system make it sure that there are always perennial salary delays in the counties, and the counties are always citing exchequer for the delays. And that has made it every time we have the industrial actions, and therefore that hampers the service delivery. And then when we have a centralized human resource management, where today a governor will not wake up and dismiss or fire doctors, we've seen in Laikipia, we saw that in Kirinyaga, and it's a trend that has been happening. There's no objectivity in the way different governors are handling healthcare. And one thing that actually we saw recently during the BBI was that the governors were feeling if the the health workers in general are taken back to be managed centrally, then they're going to lose the power to hire and fire, the power to award the relatives and even the political leaders, fellow political leaders and cronies. And that's what makes it very difficult for governors to want it to go back centrally. But I believe in terms of infrastructures, sometimes I call them white elephant projects, because you realize that very big hospitals are built in different parts of the country, but the service delivery in them is actually very limited because of the personnel, because of the drugs, even the diagnostic aspect, the labs.
They're not adequately resourced.
They're not adequately resourced.
Was there a sense, though, in devolving health? Because what is the whole rationale for devolution? Bringing services closer to the people.
Yes.
What services are people looking for on a regular basis? One of them is health.
But you see, Eric, were they receiving those services when health was under the national government? Are they receiving the same services or less now that it has been devolved?
Are the services closer to the people? Because that's the whole essence. Closer to the people.
Yes, but were they not close before?
No, they were not. There are very many who would argue that they were not. Yep. There are very many people who tell you that because of the national issue, the national government there are some areas that did not have the same access to healthcare than others. True.
That's true.
Devolution was meant now to come and close those gaps. So if it's at a local level, then the county government is able to offer the services closer to the people.
I think the challenge with...
What if it is to be, reverted to the older system, would it not be fair if maybe the government at the national level handles the personnel, but the other infrastructures are devolved so that the hospitals are built down there by the county governments, but the staffing is done at the national level?
How do you ensure that you, as the chief executive of a county who's been elected by the people, and you've said, I'm going to give you this service, how do you ensure that the national government actually gives you the personnel that you need?
That I don't think
the same thing that we're having issues with. If it's money that they have an issue, just releasing money on time. Imagine sending workers to your facilities.
But Eric, how does the government then handle teachers, for instance?
School education is not devolved.
Yeah. But also, I think the challenge we're having here is that even with the old system where healthcare was centralized, was the system working? And why was it not working? Over the years, we've seen increased privatization of healthcare. And this is where the problem is. When I was growing up, whether you're rich or poor, we used to go to the same hospital. We used to access services. I went to that hospital last year. It's now the COVID center for Busia County. And you can't imagine what you see. things used to work before. And actually, what COVID-19 has taught us is the power of public services. Everyone came back to the government. You know, the biggest private hospitals in this country were asking for a deposit of 650,000 for you to get admitted. Who can afford this? So the policy actors who are also have vested interests in these private hospitals, and they're in charge of making policy, you know, I think they're the ones who are ensuring that public services do not work for the people.
Our brother here clearly is a conspiracy theorist.
Why?
Yes. Because if I ask him to provide evidence for what he has said, will he be able to? I mean, the thinking behind it one can understand, because how do you have a situation that is untenable being perpetuated continuously, and yet nothing seems to be done? But again, I'm going back to education. Yes, education wasn't devolved. What I was referring to with reference to education was how education works. Would you say that the government is able to provide sufficient teachers and to manage the process of ensuring that learners have ample teachers in the country as they should? Do you think they're doing a good job of it?
You see, I was trying to relate how the Teachers Service Commission works, and even how the Police Service Commission and even the Armed Forces, where every year we have particular number of recruitment, annual recruitment of teachers, annual recruitment of the police, annual recruitment of the armed forces. But in the healthcare, it has been left at the accreditation of the county governors, where a governor will feel that I do not have enough budget, or I'm beyond this particular budget, and I will work with those particular doctors I have, regardless whether services are being offered or not. Because when the governors or the political leaders have a problem, they will actually go to private facilities. So in an essence, the way the teachers and the way the police and the are working is different. And that's why we're saying there's need to actually have a policy where there's annual recruitment of healthcare workers in the country based on what you've seen during this particular period of
a
COVID.
health service commission.
We could have a health service commission, or we could have even a policy directive that, okay, it's in existence actually, that every level of facility need to have a particular number of doctors, but we need to have an enforcement structure or framework to ensure that at least actually every year there's an employment that is taking place. The numbers that are being employed downward. And this is something that I was putting down to NHIF, for example, that every Kenyan contributes monetarily based on the new bill. But are you sure that once you contribute, if you go to facility A or B, are you going to get the services? Are you going to go complain to the NHIF that I don't want to contribute this month because the two facilities that were accredited to me, I didn't get services? So see, it's something that we have to look.
Yeah, but I think what I'm hearing is that there is need to review that those articles in the law and sections of the acts that stipulate the healthcare in the country, because if you go to the UK, for example, they have what is called the NHS.
Yes.
And NHS is working. What he was referring to, if anybody goes to the health facility, anybody, you will be in this room and the Prime Minister is in the other room. Because if healthcare policies are properly, done to be public friendly, then I think that will answer all the questions we are asking here. But again, I don't think the doctors are willing to go that low into accepting that they can't have their private healthcare services, because it has become something like, a huge, I don't even have the word, but it has become an enterprise for the health workers. So even when some of them are not, employed formally, they will still find their way in
locums.
To have locums or even to have private entities. I'm not in any way suggesting that there should not be employment for everybody. But I think somebody mentioned the police. When the police are needed, a specific number is taken and all of them are absorbed. So I think, again, when we advocate for policy reviews on the healthcare, such should also be, tried if they can work. Why not train the people that we need, and why not absorb all that have been trained? Yeah.
Education. You're talking about the police service and education. There's a very strong, with the police, there's a clear security element that you understand, and that's really their purpose. But with education, there is a security element, but even more so with health.
Yeah.
So if you understand you can't devolve police services so that every county has their police force, that same thinking should also have been applied to the healthcare.
So what are we going to devolve? Because we'll take that argument into food security, and agriculture should not be devolved. We'll take that argument into water and water provision. It's national. It's a national security issue. So we cannot devolve water services. What are we going to devolve?
Actually, there are fundamental differences. Why I'm saying there are fundamental differences is this. Water services with the national government, with the county governments, people still do not get services. And it has nothing to do with the availability of water or the ability of people to do it. It's just willful negligence. But something like health, something that you can't afford to play around with, literally, okay? That's why I liken it to the police force or the police service. This is not something that there should be a debate about. It's something that the citizenry should take for granted, and it's something they should assume and accept or expect to actually receive. They should expect and accept to receive water. But the management of water cannot be equated with the same way as the management of health.
I agree with you, City. I'm just saying
Yes.
that, the argument that people had when they were seeking devolution was to have services delivered closer to them in manners in which they have also accountability, and you know who you can ask if you don't get. So when you elect a governor, when you elect your MCA, I want health, I want food security, these things that you're asking for. So health is big, it's national, it's all. Is there a way in which this can be balanced, where we say that, yes, we shall ensure that our local government is providing health? There's a national policy on health, and we know it's there in place. If it's a level 2 facility, it should have this. If it's a level 3, these are the minimum requirements. Level 4, 5, 6, like that. But then also, it is the job of the county governor to make sure that if it's health workforce is present.
What I'm saying is 10 years of experimentation with the county system has shown us things. Now, should we not learn from what we have seen and said, this is what we said? Can we relook at this thing and find and find something that actually makes more sense and works? Because this one is what we thought. It's clearly not working.
And we also have case studies. If you go to Makueni, for example, how come it is working there and in other places it is not working? So this issue of goodwill, the issue of policy review, should be taken seriously, so that at least we don't leave the lives of Kenyans into the hands of a few people to determine whether they are going to have qualified doctors, enough doctors in their hospitals, and enough infrastructure for health. I think we just need to do what CT is saying, that we have experimented enough for more than 10 years now, and we are like going to go to another 10 years with the same experiment. How do we expect a different result using the same formula?
But Reverend, why is it working in Makueni? That's a question we should.
Because somebody somewhere took upon himself to enforce this. So if others have to be whipped to enforce it, then we have to have a policy that whips them, so that
what you're saying,
the doctors is representing, the health
so the
workers
issue, the devolution is not to blame.
It's not devolution to blame. No. What is to blame is the policy, the framework to enforce what is already in writing.
I think for me, it's the failure of leadership, because clearly in Makueni, the reason it's working is because there's leadership there. There's true leadership. You have someone who believes in the power of public services. You have someone who believes in delivering services for the people. But do the rest of the leaders in the counties believe in the same? So when we're talking about policy review, is the policy the problem, or is the leadership the problem?
I think with devolution, if we just do a survey of the counties, as you say, Makueni, I think Nakuru, we realize the healthcare system is a bit different. They have what we call the hospital management fund, where the funds collected in a facility is ring-fenced to that particular hospital. It doesn't have to go to the national, to the county accounts, kitties. And that's why they've been working. But essentially, I think there's need to be an enforcement structure
Yeah.
to the governors and the leadership of the counties to make actually things work. Because when a governor decides to do something, he doesn't care. Even if it report it to the president or to the courts, they don't care. And there's nothing that can be done. And that has been happening. And that attitude is what is making most of the things not able to work in the counties with the healthcare.
You know, when you talk about the leadership gap, you are right. But have you considered perhaps that for many of our governors, this job of governors was actually beyond their capacity?
That's true.
They got jobs they actually couldn't do.
They don't
They
understand
don't even
actually.
know
It's
how.
a thing.
They don't even know how. and again, when you get into the office, what do you do first? If you can't put structures on how you are going to work, then how do you expect a miracle to happen? If you go to Makueni, for example, Governor Kivutha had to set some parameters, some structures, so that when he begins to work, then he knows what
There's a framework within
which he works. And then, if it is the issue of financial management, he has just given us an example that he had to set up a pool that is not interfered with by anybody, but is specific for healthcare. So that can be done, and if it is something to learn from, then the enforcement framework that we are talking about should have a leaf from what they are doing in Makueni, what they are doing in Nakuru.
How would this enforcement framework look like? You're talking about enforcing somebody else enforcing somebody who's been directly elected by the people and given the executive mandate. So what is it that you do? What stick is this that you would use?
Remove that power from them. It's very simple.
No, you don't remove the power from them. You curtail the power within a framework.
You see, there's one thing that is in the counties. In the counties, the governors can direct budgets anyhow. As much as we have the Public Finance Act to manage how they use the funds, the monies that are meant for salaries can actually be directed to something else. The monies that are meant for employment, promotions can do something else, which is not healthcare related. Because as I said earlier, for the governors, when there's an hospital that has been built and it looks beautiful, the White Elephant Project, then they want to say, we have an hospital, we are okay, the governor has done this. So that hampers the service deliveries. But I think generally what will really help healthcare is to have an independent set of a structure for to manage the human resource for health. Because even now, as we speak, we have interns, more than I think 300 or 400 of them, that are under the Ministry of Health that have not been paid for over 4 or 5 months. So it then the issue.
And this is from a national level.
This is now from ministry level, and then they'll cite the issues of the delayed payroll system, the delayed disbursement from the treasury, and there are even more who have not been posted. So it then means that we need just a structured system that ensures that the human resource, the doctors, the nurses, all these personnel are well handled and well posted, devoid of any emotion that could be from leaders. Yes, I think it will work.
Indeed. Well, thank you very much, gentlemen, for joining us this morning. 1 hour is a short time, right? When you're having such a... This conversation ought to continue in coming days because we have to look back at... There's something that COVID-19 has taught us. Have we taken the lessons? Are we starting to apply those lessons? And in very many ways, we're saying we're still talking about the lessons that we've learned, but application of the lessons is not yet to beginning. The conversation continues into the next hours. We've been live on KTN Home. We want to say goodbye to the audience on KTN Home. We continue the conversations on SpiceFM around the country. Dr. Davji Attelah is the Secretary General of the Kenya Medical Practitioners and Dentists Union. The Reverend Elias Agola is from the National Council of Churches of Kenya. And Joab Okanda is a Pan-Africa Senior Advocacy Advisor at Christian Aid. Thank you very much for tuning in to Kenya's biggest conversation.
Spice.